Hey guys, welcome back to my channel, The ENT Resident. Today I'll be doing another case discussion on a very important and a very common case you get in your practical exams, both as a long and a short case, and that is bilateral ethmoidal polyposis. We will be discussing right from history, clinical examination, how to summarize the case, how do we arrive at a provisional diagnosis, what are the differential diagnoses, and finally, how we'll manage the case. Now you can also purchase my notes. I have added some links in the description. So let's get started with the case now. Coming to history. Ravi, a 32-year-old male residing in Bangalore, Hindu by religion and software engineer by occupation, presented with the chief complaint of bilateral nasal obstruction since 1 year. Now, coming to history of present illness, patient is apparently asymptomatic 1 year back when he started complaining of nasal obstruction on both sides, which is insidious in onset. It started on the right side first, followed by the left, gradually progressive in nature to reach the current state. There is a partial obstruction on each side, which increases while lying down and on exposure to dust. There is no diurnal variation. It is aggravated by cold weather and temporarily relieved on using nasal drops. It is associated with watery nasal discharge, which is non blood tinged and non foul smelling. It is associated with reduced sensation of smell, sneezing, and watering of eyes, and also associated with snoring. Coming to negative history, there is no history of headache, mouth breathing, chronic irritation in throat and throat clearing, trauma, bleeding from nose, any ear complaints, fever, cough, double vision, changes in voice, loosening of tooth, significant weight loss. Coming to past history, there is no history of similar complaints in the past, no history of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, no history of surgeries in the past, no history of known drug allergy. There is no significant family history. In treatment history, there is a history of usage of nasal decongestant drugs. Coming to personal history, sleep is reduced, appetite is normal, diet is non vegetarian, and bladder and bowel movements are normal. And there is no addiction history. So now, this was all about the history. Now let's discuss each point in history. First, let's discuss the patient particulars and what are the importance of noting all of these patient particulars. First of all, let's talk about age. What is the importance of age here? And are there certain diseases that are more common in childhood or that are more common in elderlies? Or is there even a bimodal distribution of age in certain disease? So, in the young adults, especially in young people, especially in adolescents, a very common disease is juvenile nasopharyngeal angiofibroma. You usually see it in adolescent males. This is a very typical feature. And in young children, Ethmoidal polyp is more common. Whereas in middle-aged people, you see rhinosporidiosis, ethmoidal polyp, and inverted papilloma to be more common. Whereas in elderly, sinonasal malignancy is very common. And there are two disorders in the nose where we see a bimodal age distribution. One of them is olfactory neuroblastoma, which has two peaks, one at around 20 years age and the second one around 50 years age. And second is nasopharyngeal carcinoma, which has its first peak around 10 to 20 years and second peak around 40 to 60 years. Next, let's talk about gender. Now, there are certain diseases that are common in males, and there are certain diseases which are more common in females. Such a few names are in males, juvenile nasopharyngeal angiofibroma, rhinosporidiosis, carcinomas, and inverted papilloma have a higher incidence. Whereas in females, atrophic rhinitis, olfactory neuroblastoma, and malignant melanoma have been seen to be more common. So, this is the importance of the gender of the patient. There are certain diseases that predispose certain genders. Now, next, moving on to occupation. Now, we need to know what are some occupations that have increased risk of certain diseases in the nose. For example, farmers have been seen to be more commonly having rhinosporidiosis. Whereas people who have more exposure to dusty environment, any occupation that leads to that, they have more incidences of vasomotor rhinitis. Pollen exposure is associated with allergic rhinitis and nasal polyps, whereas nickel and wood industry is seen to be commonly having sinonasal malignancy. And amongst it, exposure to hardwood leads to adenocarcinoma, and exposure to softwood leads to squamous cell carcinoma. So these are some diseases in the nose where the occupation is very important, and you need to take the history to find out if any risk factor has been present in the patient. Next, we move on to knowing the region of the country where the patient is from. Now, there are two important things over here. In northern India, it has been seen that rhinoscleroma is more common over there, whereas rhinosporidiosis is a disease which has been seen to be more common in the coastal areas of southern India. So, there are certain diseases which are more in certain areas of the country. Next, moving on to our chief complaint. So, our chief complaint was nasal obstruction on both the sides. Let's discuss each point one by one and what is it that you can infer from each point. According to the history, the nasal obstruction started on the right side first, followed by the left side. So, here we can see that the patient has presented to you with bilateral nasal obstruction. So, what are the possible differential diagnosis over here just based on this point? The most common of them is ethmoidal polyps, bilateral choanal atresia, nasal allergy, vasomotor rhinitis, atrophic rhinitis, acute rhinitis and sinusitis, adenoid hypertrophy, juvenile nasopharyngeal angiofibroma, septal abscess, and rhinitis medicamentosa. So, these are some causes of bilateral nasal obstruction. So, now our patient can probably belong to any one of these causes. Let's discuss the next point. So, this nasal obstruction is gradually progressive in nature to reach the present state. So, what does that mean? So, there can be two types here. Either the condition is gradually progressive or it is rapidly progressive. Now, any rapidly progressive condition always points towards the presence of a malignancy, whereas gradually progressive could be any benign condition. So, that is any benign condition which can include not only benign tumors but also polyps as well. So, that is about gradually and rapidly progressive. Next, the nasal obstruction has been seen to be increasing while lying down and on exposure to dust. Now, what does this have to do and what does this indicate? So, the nasal obstruction, which increases on lying down, this means when the patient, why is this happening, first of all? So, when the patient lies down, what happens is the mass in the nose may fall backward into the choana and the nasopharynx. Thus, it ends up in obstructing the airway more significantly. Secondly, lying flat also increases the venous pooling in the nasal mucosa, and this can further cause mucosal swelling and worsen the nasal obstruction that is already felt by the patient. And third, when you lie down, mucus may pool over there, adding to the feeling of blockage. So basically, all of these three reasons are the reason why any nasal mass can actually lead to more obstruction when the patient lies down. Now, the second point where it is saying that the nasal obstruction increases on exposure to dust, this is basically suggesting there is probably some allergic etiology involved over here. Let's discuss the next point. This nasal obstruction, it does not have any diurnal variation. Now, what does that mean? Any nasal obstruction which is changing throughout the day, it usually means that it is not due to any structural cause. Whenever there is a structural cause, what do you mean by structural cause? Any problem in the structure of the nose, which probably a good example would be having a deviated nasal septum. Now, that is something that will be constant throughout the day. It will not keep having changes. So, whenever there is no diurnal variation, it is usually suggestive of being a non-fixed dynamic cause of nasal blockage rather than a structural lesion. Now, what are some diseases where you see a diurnal variation in nasal obstruction? It could be a nasal polyp, a tumor, a foreign body, even chronic fungal sinusitis. Next, This nasal obstruction is temporarily relieved on using nasal drops, which means that probably it could be a reason that allergy is causing the disease. So, whenever you're using nasal decongestant drops, it is causing vasoconstriction and giving a temporary relief. Now, a good Viva question over here would be, could you name a condition where you use nasal decongestant drops so much that instead of relieving your nasal congestion, it actually causes rebound congestion? Now, this disease is known as rhinitis medicamentosa. This is also a very important disease, and this is the reason why nasal decongestant drops are usually given only for 5 to 7 days at the most at a go. You should not be using it more than 7 days, definitely, because it can lead to rebound congestion. So it'll lose its efficacy right over there. Next, this nasal obstruction is associated with watery nasal discharge, which is non blood tinged and non foul smelling. So now from here, we need to know what other types of nasal discharge are there? What are the causes of blood tinged nasal discharge and what are the causes of foul smelling nasal discharge? So, first of all, there are three different types of nasal discharge. There is watery, mucoid, and purulent. Now, watery nasal discharge is most common cause would be allergic rhinitis. Other causes include vasomotor rhinitis, CSF rhinorrhea, and ethmoidal polyposis. The causes for mucoid nasal discharge would be antrochoanal polyp, allergic fungal sinusitis, choanal atresia, and ciliary motility disorders like Cartagener syndrome. And last of all, purulent nasal discharge is seen in more infectious cases like a long-standing foreign body, bacterial rhinitis and sinusitis, atrophic rhinitis, infected polyp, furuncle, and septal abscess. So these are the three different types of nasal discharge, and they each indicate towards certain causes that may be causing it. Now let's move on to blood-tinged nasal discharge. What are the causes of that? Some of them include juvenile nasopharyngeal angiofibroma, a neglected foreign body. So GNA is something you will be seeing in adolescent males. Neglected foreign body more commonly seen in children. Rhinolith, rhinosporidiosis, which is a granulomatous disease of the nose. There are other granulomatous diseases of the nose which can also cause it, like vaginous granulomatosis, lupus, leprosy, etc., TB. And then there is sinonasal malignancy, atrophic rhinitis, and trauma. Now, in trauma, we do see bloodstained nasal discharge, but there can also be frank bleeding from the nose. So these are all the causes of bloodstained nasal discharge. Next, let's try to understand what are the causes of foul-smelling nasal discharge. Some of the most common ones include foreign body, atrophic rhinitis, fungal sinusitis, myiasis. There can even be malignancy. There can be purulent bacterial rhinitis and sinusitis. So these are some of the causes of foul-smelling nasal discharge. Now, amongst this, there are two very important MCQ questions that you get in your entrance exams or can be even asked in Viva. And the questions are, when you see a unilateral foul-smelling purulent nasal discharge in children, this will always, you have to be certain that this is probably a foreign body of the nose unless it has been proved otherwise. And if the same condition happens in an adult, we suspect the presence of sinonasal malignancy. So these are two very important MCQ that you need to know. Next, this patient is also complaining of a reduced sensation of smell. Now, a reduced sensation of smell means that the patient probably has hyposmia. Now, in my previous video where on the antrochoanal polyp case discussion, I have discussed certain terms related to smell like anosmia, parosmia, cacosmia, hyposmia. Those are all terms and definitions that you need to know. Since I've already discussed it, I'll not be discussing here. So certain causes of anosmia or hyposmia include deviated nasal septum, rhinitis, sinusitis, injury to the cribriform plate, atrophic rhinitis, following viral fever, and most commonly in the recent years, it has been COVID-19 viral infections. So, what is the anosmia that we see in atrophic rhinitis called as, and why do we call it such? So, the anosmia in atrophic rhinitis is known as merciful anosmia, and there's a reason for that. So, a very chief complaint when the patient comes to you with is the fact that the people around the patient, they complain of a foul smell coming from the patient. But however, the patient himself is not aware of the foul smell coming from him. So, as a result of which, the patient ends up being a social outcast. And the reason why he's not able to get the smell himself is because he himself has loss of sensation of smell, meaning anosmia. So, this is why the condition is known as merciful anosmia in atrophic rhinitis. Now, why do we see anosmia in atrophic rhinitis? There are three reasons over here. First of all, there is a loss of olfactory neural elements. Secondly, thick secretions and crusts cover the olfactory area, therefore, it prevents its contact with the air current. And thirdly, there is a degeneration of seromucinous glands, leading to insufficient mucus available to dissolve the odoriferous material entering the nose. So, this is why we see anosmia in cases of atrophic rhinitis. Next, the last history over here is that it is also associated with snoring. Now, snoring indicates that there is a obstruction in the airway passage somewhere. So, it is a very non-specific complaint, but it does add up to reaching your provisional diagnosis. Now, let's discuss about all the negative histories. First, there is no history of headache. Now, when there is a history of headache, what does it mean? So, history of headache usually rules, when there is no history of headache, it usually rules out sinus involvement. We see headache in sinusitis and intracranial spread of sinonasal malignancy. But in intracranial spread of sinonasal malignancy, we see other features of intracranial involvement like altered sensorium, vomiting, nausea, seizures, etc. Now, as we're talking about sinusitis and headache, let's know what are the different places where the headache is felt in the different sinuses. Now, in case of frontal sinusitis, there is a term that is used which is known as head office headache. And this headache is felt in the supraorbital region. Why is it called office headache? That's because what happens is when the patient is lying down at night, all the secretions start collecting in the frontal sinus. Now, when the patient wakes up in the morning, the headache starts sometime in the morning and it reaches its peak in the afternoon, and then it starts subsiding as the day passes by evening. So, what happens here is the maximum pain is felt during the afternoon. And as the day keeps passing, the sinuses keep draining, and as a result of which, headache reduces. So, this is called office headache because it persists only during the office time. Second, we see an infraorbital pain in the maxillary sinusitis. Third, in ethmoid sinusitis, we feel a pain over the bridge of the nose and between the eyes. And lastly, sphenoid sinusitis pain is seen over the occipital region, pain at the vertex, and even retroauricular pain. So these are the four sinuses when there is an inflammation of the sinuses that leads to pain in different parts of the head. There is a disease which is known as Sludder's neuralgia, and this is a very common viva question you get during your practical exams. What is Sludder's neuralgia? Sludder's neuralgia is basically when a high deviated nasal septum presses on the middle turbinate, and this causes pressure on the sphenopalatine ganglion. As a result of this, it causes pain from the eyebrows down the nasal bone. But the pain is not so severe. However, you feel uncomfortable while wearing spectacles. There are two other names by which we know this disease as. One is anterior ethmoidal neuralgia because the anterior ethmoidal nerve gets involved, and also it is known as sphenopalatine neuralgia because the sphenopalatine ganglion is involved. Next, coming to history of mouth breathing. This history rules out complete obstruction of the nose. If there is indeed a history of mouth breathing, in a younger patient, you should definitely suspect adenoid hypertrophy because it is a very important and very common disease that children come to you with. Other than this, there can also be a nasopharyngeal mass which can lead to mouth breathing. Now, as we're talking about adenoid hypertrophy here, there is a facies that is very commonly asked to you, the features of which you need to know, which is adenoid facies. So, what is adenoid facies? Adenoid facies actually has a lot of features. First of all, they have an elongated face. This happens because there is a vertical maxillary overgrowth due to altered jaw development. And the patient also has a very dull mask-like face with a very vacant stare. There is not much expressions on the face. There is mouth breathing in the patient, flattened nasal bridge, which happens due to the underdevelopment of nasal structures. A pinched nose is seen with narrow nostrils and nasal speech. So these patients actually have hyponasality, which is also known as rhinolalia clausa. The patient also has sunken eyes, an open mouth, which happens because of the mouth breathing that they get used to, a high arched palate, which results due to improper tongue posture and mouth breathing. There is crowding of upper teeth because of a narrow upper dental arch and a short upper lip with exposure of upper incisors. Next negative history is there is no history of throat clearing. Now, usually, a history of throat clearing indicates the presence of a postnasal drip, and postnasal drip is more commonly seen in cases of sinusitis. Next, a history of trauma usually will indicate towards an underlying nasal fracture. A history of bleeding from nose is very important because this will help you in differentiating from all other cases of nasal mass where they have blood-stained discharge or even frank bleeding from the nose. Some of the examples would be sinonasal malignancies, there can be inverted papilloma, there can be rhinosporidiosis, and a lot of other granulomatous diseases of the nose. History of ear complaints is also important because an infection, there are two reasons over here. One is if there is an infection in the nose and nasopharynx, it can impact the ear by occluding the eustachian tube. And when the eustachian tube gets occluded, there is a reduced drainage and ventilation of the middle ear that leads to the development of serous otitis media. Secondly, a nasal mass which extends into the nasopharynx can also obstruct the eustachian tube. A history of fever usually indicates the presence of an active infection, and a history of cough can be indicative of tuberculosis and other granulomatous diseases where there is systemic involvement seen. Next, a history of double vision. Now, what does a history of double vision indicate? It can involve, there are multiple ways that double vision can be caused. When there is involvement of the medial rectus muscle in malignancy, that can lead to diplopia. Intraorbital spread of sinusitis can also lead to diplopia. Cavernous sinus thrombosis as a result of sinusitis and malignancy can be a way to cause diplopia. And nasal masses with orbital invasion also can cause diplopia. So these are all the reasons why you may see double vision. So whenever there is an absence of double vision, it means that the orbit has not been involved and there is no cavernous sinus thrombosis. Next is a history of change in voice. So there can be two types of change in voice. One is hyponasality, also known as rhinolalia clausa, and it is seen in diseases like polyp, adenoid hypertrophy, and nasopharyngeal mass. Whereas hypernasality, also known as rhinolalia aperta, is seen in cleft palate, palatal palsy, and veropharyngeal insufficiency. Next is a history of loosening of tooth. This is more commonly associated with sinonasal malignancy, which is involving the maxillary sinus. And a history of significant weight loss can indicate the presence of malignancy or tuberculosis. So, this is all about the negative history and what they help you in ruling out. What are the conditions that are ruled out from taking a negative history? Next, let's move on to past history. So we have to ask about if there is a history of similar complaints in the past. Since this patient has history of no such history of similar complaints in the past, it does not really indicate a lot. But in case there are similar complaints in the past, it is usually indication of the recurrence of the disease. So it can be recurrent ethmoidal polyp. It can be a recurrence of sinonasal malignancies as well. Secondly, diabetes mellitus and hypertension. These are two systemic conditions which are very important to ask about, especially from the perspective of preoperative evaluation of the patient. A hypertensive patient usually has more chances of bleeding from the nose. So it is very important to control the blood pressure before the taking the patient up for surgery. Whereas diabetes mellitus patients, these patients are more prone to having fungal infections of the nose in them. So it is very important to take these histories in the past history as well. Next is bronchial asthma. Now, why is bronchial asthma history relevant in the case of ethmoidal polyposis? That's because we are trying to look for features of Samter's triad here. Now, what is Samter's triad? Samter's triad is this triad which is also known as aspirin exacerbated respiratory disease. Now, in this disease, there are three features that we see. One is nasal polyp, which is ethmoidal polyp. Second is asthma, and third is aspirin or NSAID sensitivity. So these three features together make up the Samter's triad. Secondly, the importance of bronchial asthma is it is also important from the perspective of preoperative evaluation because in usually endoscopic sinus surgeries, we use hypotensive anesthesia. So, beta blockers are used over here. And sometimes beta blockers can cause bronchospasm, which can actually worsen the case of bronchial asthma. So, it is very important to know whether your patient has bronchial asthma or not. Next is tuberculosis. Tuberculosis is a disease which mainly affects the lung, but also one of its rarer sites of involvement is the nose. Now, when it does involve the nose, it has a lot of features like it can cause a nasal obstruction, foul smelling nasal discharge, which can be blood-stained, purulent, and persistent. There can be recurrent epistaxis, nasal crusting, ulcers or granulation, septal perforation, a saddle nose deformity, and also, very importantly, presence of constitutional features like low grade fever, weight loss, and melee. So, this is all about the past history. Now, let's move on to all the family history, which is not very significant here. There is a history of nasal decongestant drops. However, the patient says that it is temporarily relieved only. This does indicate that there could be an allergic component involved over here. Next, the patient has also complained of sleep being reduced due to nasal obstruction. This probably happens because of because the masses in the nose, the polyp in the nose is occupying the complete nasal cavity. This is why it is difficult for the patient to breathe through the nose, as a result of which sleep is getting disturbed. And no addiction over here is a very important history over here, which is a history which is important in telling you probably there are lesser chances of this being a malignant case. Next, let's look at what do we find in the clinical examination of the patient. Facial symmetry is present, skin, external osteocartilaginous framework, bilateral ala, columella, and vestibule. These are all normal. On anterior rhinoscopic examination, the septum is seen to be in the midline. On the right side, the floor is normal. Inferior turbinate is not visualized properly. There's bilateral multiple pale glistening polypoidal masses seen filling the left and right nasal cavity, which is appearing like a bunch of grapes. Its surface is smooth, mobile, insensitive to touch, doesn't bleed on touch, soft in consistency, and can be probed all around. The mucosa is pale. Left side, the floor is normal, and we see the same findings in the left side as well. Posterior rhinoscopy is normal. Paranasal sinuses, there is no redness or swelling seen. All sinuses are non-tender. Functional test on both sides, there is no improvement on Cottle's test. On cold spatula test, there is decreased misting. On cotton wool's test, there is a reduced movement seen, and smell is absent on both sides. And rest all other examination is normal. Now let's discuss each of the clinical examination features that we have come across and what do they indicate towards. So looking at first nasal nose examination, we've said that the vestibule is normal. Now can you tell me what is vestibule? Vestibule is actually the anterior part of the nasal cavity, which is lined by skin and hair follicles. And can you name a few diseases of the vestibule? The first one is very easy over here because it is lined by hair follicles. It actually leads to acute infection of these hair follicle, leading to the development of furuncle. So, furuncle is basically acute folliculitis of the hair follicles. Then, other diseases include vestibular stenosis, vestibulitis, where there is a diffuse inflammation, diffuse dermatitis of the vestibule, nasoalveolar cyst, papilloma, and squamous cell carcinoma. These are just a few viva questions that may be asked in relation to vestibule. Next, looking at the anterior rhinoscopic findings. So, first question that comes in, what instrument do you use to perform anterior rhinoscopy? So, the name of the instrument is Thuticum's nasal speculum. And how do you perform anterior rhinoscopy? Now, this is something that undergraduate students get very confused about as to how to hold the Thuticum's nasal speculum to perform anterior rhinoscopy. So, first of all, what you do is see in the first image over here, you hold the speculum at the junction of both the prongs of the speculum with the help of the thumb and the index finger in the left hand. And the blades of the Thuticum speculum should always be facing towards the patient. That is very important. Next, the spring action of the prong is controlled with the help of your ring finger and your middle finger. You can see that in the image over here. The middle finger and the ring finger, these two fingers are used to control the spring action of the prongs. Now, how do you introduce it? First, you press on the prongs and make it closed. With the blades closed, you introduce the nasal speculum into the nose of the patient. And once you introduce it to the nose, then slowly you release the spring action to open up the blades and examine the nasal cavity. So that is how you perform anterior rhinoscopy. So this is something you may be asked to demonstrate on your practical exams. Now that you're performing anterior rhinoscopy, it is very important to know what are the structures that you are supposed to notice in the examination. First of all, we look at the nasal septum. Is it in the midline or is it deviated? Is there any septal perforation or any septal abscess? Is there any presence of spurs? Next, you look at the nasal mucosa. Normally, the nasal mucosa is pinkish in color. When it is seen to be bright red, it is suggestive of acute inflammation, and it is pale white in cases of allergy. Next, we look at the nasal floor, if there is any presence of foreign body or any rhinolith or any secretions. Next, looking at the lateral wall. So, in the lateral wall, we see the anterior ends of the inferior and the middle turbinate and their respective meatus. And next, we look at the nasal cavity. Now, both cavities, ideally, they should be equal on both sides. A wide cavity is when you are able to view the post nasal space as well. That's when you can call it as a wide nasal cavity. Other than this, you look for any kind of secretion, foreign body, maggots, tumor, polyp, adhesion, any kind of mass, any other finding that you may see in the nasal cavity. Lastly, if there is a lesion present, you look at the surface, the color of the lesion, if there's any ulceration, and you use a probe to see the consistency, sensitivity to touch, and bleeding on touch. So these are all the things that you look at while you're performing the anterior rhinoscopic examination. Now, this is what we have seen when you have performed anterior rhinoscopy in this patient, that there is bilateral, multiple, pale glistening polypoidal masses in both the nasal cavity, appearing like a bunch of grapes. It has a smooth surface, mobile, insensitive to touch, doesn't bleed on touch, soft in consistency, and can be probed all around. Now, all of these features are very, very important, and all of them together is leading to your diagnosis of ethmoidal polyp. So, let's discuss each one of these features and why are we seeing these features in ethmoidal polyp. First of all, it is a soft, pale, glistening mass. On probing, we see that the consistency of the mass is very soft and gelatinous. Why? Because polyp is essentially a hypertrophied edematous mucosa. That is why the consistency is very soft. We are seeing that the probe can be passed all around the mass. This indicates that the mass is free and it is not attached like a turbinate, for instance. Polyps are actually mobile and not fixed to any surrounding structure. Next, we also saw that the mass is insensitive to touch, which means it is not tender to touch. Why? Because polyps are actually edematous mucosa and they do not have any nerve endings, because of which there is no pain on probing. Lastly, we see that it also does not bleed on probing. Now, ethmoidal polyps, these are composed of edematous tissue with very few blood vessels. Because of this avascular nature of the ethmoidal polyp, there is no bleeding on probing. Unlike in tumors or any other inflammatory condition where you can see bleeding on touch. So, this is how we explain all the little features that we have seen on anterior rhinoscopy of the mass. Now, a very important question here would be, how would you differentiate whether what you saw is a polyp or is it a hypertrophied turbinate? There are certain distinguishing features over here. Polyp is usually a pale, smooth, and glistening mass. Important word being pale, whereas inferior turbinate is actually a soft pinkish mass which is normal in anatomy and it is seen to be arising from the lateral wall of the nose. Polyps are insensitive to touch and inferior turbinate is sensitive to touch because they have nerve endings. Whereas polyps are actually edematous mucosa which do not have any nerve endings. Polyp is usually mobile and not attached to any structure. Inferior turbinate is not mobile and it is attached to the lateral wall of the nose. And a very, very important factor over here is the use of nasal decongestant drops. Polyp will not shrink on using the drops, whereas inferior turbinate will definitely shrink on vasoconstriction. And that's how you confirm that what you have seen is a hypertrophied turbinate, inferior turbinate. Next, can you name some condition where on probing, where doing the probe test, the mass bleeds on touch? This is very important to know because this is a whole other differential diagnosis whenever a bleeding mass presents to you. Now, the conditions include inverted papilloma, sinonasal malignancy, rhinosporidiosis, juvenile nasal angiofibroma, hemangiocytoma, capillary, which can be both capillary as well as cavernous, and hemangiopericytoma. So these are all the conditions in which you see a nasal mass that will bleed on doing the probe test. Next, let's look at the functional test. From all the findings that we have seen in the functional tests, it indicates that there is an obstruction of both the nasal cavities. However, in Cottle's tests, we see that there is no improvement on both the side. Now, what does that indicate? For that, we have to know what is Cottle's test. Now, Cottle's test, what is it testing? We are checking if there is any pathology of the internal nasal valve. How do you perform this test? You can see in the image over here, you pull the cheek away from the midline. If on doing that the nasal airway improves, that means the test is positive and it will indicate an abnormality in the nasal valve, internal nasal valve area. What does negative Cottle's test indicate? It indicates the fact that the obstruction that has happened is likely due to causes other than involving the internal nasal valve. Now, since we are talking about the internal nasal valve, the next question that will be asked to you is, can you name the boundaries of internal nasal valve? Internal nasal valve is actually the narrowest part of the nose. If you see in the image over here, it is bounded medially by the septum, which is marked by number 1. It is bounded laterally by the caudal edge of the upper lateral cartilage and the head of the inferior turbinate, and it is bounded inferiorly by the nasal floor. You can see in the image over here, the nasal septum is the medial boundary, the lateral cartilage is the lateral boundary, and inferiorly is the nasal floor. So these are the boundaries of the internal nasal valve. Next, since we are talking about Cottle, there are a few other things that you need to know. One of them is, what is Cottle's line? Second is, what are Cottle's areas? And is there anything else related to Cottle that we know in ENT? Now, first, let's talk about Cottle's line. Cottle's line is actually this vertical line, the line that you see in the image over here, which extends between the nasal process of the frontal bone and the nasal spine of the maxillary bone, maxillary crest. This vertical line basically divides the septum into an anterior portion and a posterior portion. That is the importance of Cottle's line. Next, what are Cottle's areas? Now, Cottle's areas, there are total 5 Cottle's areas. And you can see in the image over here, the first area 1 is the nostril. Second area is the nasal valve area. Area 3 is the area which is underneath the bony and cartilaginous junction, a cartilaginous vault. This area is known as the attic. Area 4 is the anterior part of the nasal cavity, including the heads of the turbinates and infundibulum. And area 5 is the posterior part of the nasal cavity, which includes the posterior ends of the turbinates. This is a very, very important viva question that will 100% be asked if you get a nose case. Next, what other Cottle is related to ENT? Is there anything else? There is actually an instrument which is called the Cottle's elevator. And this instrument is used in septoplasty, SMR, and rhinoplasty. And what do we do with it? We actually elevate the mucoperichondrium from the septal cartilage and the mucoperiosteum from the bony septa. So this is all about Cottle's that you need to know. There is Cottle's test, Cottle's line, Cottle's areas, and Cottle's elevator. Next, let's talk about when you're testing smell. What objects do you use to test smell? The most common ones are coffee beans, garlic, and asafoetida. However, the one thing that you definitely should not use to test smell is ammonia. And why is that? Because ammonia is actually an irritant. What it does is instead of stimulating the olfactory epithelium, it irritates the trigeminal nerve ending, leading to a false impression that the patient has actually smelled something. That is why you should definitely not use an irritant material to use to test smell. And another thing that you need to know whenever you're testing for smell, you should definitely first check the pathological site, because if you first make the patient test the patient on the normal side, the patient will already know what object you have given. So even though when you test on the pathological side, maybe the patient is actually not able to smell it, however, they'll end up saying the right thing because they already know what is the object that you are presenting to them. Leaving all of this aside, can you tell me what is the gold standard for testing smell? It's actually none of these clinical examination, but rather it is a test called UPSIT, the full form of which is University of Pennsylvania Smell Identification Test. This test actually has a total of 40 questions, which is divided into 10-page booklets of 4 different kinds. On each page, there is actually a scratch and sniff strip, which is embedded with some kind of micro encapsulated odorant. And you have a 4-choice MCQ on each page. So what you do is the scent are released by scratching the pencil on top of these strips. And once the scent is released, the patient smells it and detects the odor from the 4 choices that is given to them. So that is about the gold standard for testing of smell. Next, we have seen that all the other examination is normal. Now, what does that mean? What is the importance of doing these examination in case of a nose case? So first of all, the importance of oral cavity and oropharynx examination. What can happen here is one, if there is a mass hanging behind the uvula, it can be possible due to an enlarged anterochoanal polyp which is grown backwards and posteriorly, and it has then grown downwards to hang behind the uvula. Sometimes a mass in the nose or the nasopharynx can even cause a bulging of the soft palate. And thirdly, in nasopharyngeal carcinoma, what happens is we see a cranial nerve involvement of 9th, 10th, 11th, and 12th. As a result of this, there is a loss of movement of the soft palate. So, examination of the oral cavity as well as the oropharynx can actually help you in determining if there is a nasal mass which is intruding into the oropharynx. Next, what is the importance of ear examination? Now, anything that happens in the nose, it also can affect the ear in certain ways. For example, if there is a mass growing inside the nose or the nasopharynx, it can lead to eustachian tube edema or blocking the eustachian tube. And hence, it will lead to reduced ventilation and drainage of the middle meatus and lead to development of serous otitis media. So, if serous otitis media develops, the ear will reveal a retracted tympanic membrane, a tympanic membrane which is dull, and also there will be a loss of light reflex, and sometimes you can even see air fluid levels. You will be able to see bubbles inside the through the tympanic membrane. And if there is a development of acute suppurative otitis media, in that case the findings you will see would be a retracted and congested tympanic membrane, a bulging tympanic membrane if it is the stage of suppuration, cartwheel appearance if there is a stage of presuppuration. Next is, what is the importance of neck examination? In case there is a sinonasal malignancy, the mass is actually a malignant mass. In that case, cervical lymph nodes can get involved. Even in case of nasopharyngeal carcinoma, cervical lymph node enlargement will be seen. So that's what it will indicate towards. So that is why we should definitely do neck examination as well. Now let's summarize the case. So this is a case of 32-year-old male who came with a chief complaint of both-sided nasal obstruction for a year. Nasal obstruction is insidious in onset. It started on the right side first, followed by the left, gradually progressive in nature to reach the current state. Partial obstruction on each side. It increases while lying down and on exposure to dust. No diurnal variation, aggravated by cold, and temporarily relieved on using nasal drops. It is also associated with watery nasal discharge, which is non blood tinged and non foul smelling, and associated with a reduced smell sensation, sneezing, watering of eyes, and snoring. On examination, we find that there are bilateral multiple pale glistening polypoidal mass seen to be filling the left and right nasal cavity, and it is appearing like a bunch of grapes. It has a smooth surface, mobile, insensitive to touch, doesn't bleed on touch, soft in consistency, and can be probed all around. The nasal mucosa on both sides is pale. Cotton wool test has shown reduced movement on both sides. Whole spatula test has shown reduced misting on both sides, and smell is absent on both the sides. So these are all the features in terms of history and clinical examination you have seen in this patient. Now that brings us to, what is your provisional diagnosis from all of this? So, our provisional diagnosis here is that this is a case of bilateral sinonasal mass, likely to be bilateral ethmoidal polyposis. Now, the very next question that will be asked to you, what are the points which is in favor of your diagnosis? What all features have led you to the diagnosis of bilateral ethmoidal polyposis? So first of all, from history, we have seen that this is a history of bilateral nasal obstruction, which has been gradually progressive. And there's also a history of watery nasal discharge, which points towards ethmoid polyposis. And the discharge being non-blood tinged and non-foul smelling have ruled out a lot of other differential diagnoses, including malignancies and other masses or granulomatous conditions of the nose. A history of sneezing, watering of eyes, and snoring has actually pointed towards allergy as a causative factor over here. And there is no history which is suggestive of malignancy, for example, diplopia, bleeding from the nose, or loosening of tooth, or headache, or any such history which can be suggestive of malignancy. So, from history alone, it has all pointed towards bilateral ethmoidal polyposis so far. And even from examination, we see that there is actually bilateral multiple pale polypoidal masses on both the side. It appears like a bunch of grapes, which is the typical appearance of ethmoidal polyposis, has a smooth surface. Mobile means it is not attached to anything. It is just a it is a hyperprolapsed edematous mucosa. It is insensitive to touch because it does not have any nerve endings. Does not bleed on touch because it is not a vascular mass but is just a edematous tissue. Soft in consistency, and it can be probed all around. And also pale nasal mucosa. So, all of these together, they are all suggesting that this is probably a case of bilateral ethmoidal polyposis. Next, now that we have come to the diagnosis of that this is a case of bilateral ethmoidal polyposis, the very next question is, what is a polyp? A polyp is actually defined as inflammatory, non neoplastic, hypertrophied edematous mucosa prolapsing out of the nose or paranasal sinuses. Now, how does a polyp formation happen? What are the stages of polyp formation? So, there are four stages of polyp formation. First, there is a stage of initial inflammation, where the trigger is usually either a long standing infection or allergy. Infection is more commonly seen in AC polyp, and allergy is more commonly the cause of ethmoidal polyp. So, there is after this trigger, there is a persistent inflammation of the nasal and sinus mucosa. This leads to the second stage, which is the stage of edema. Now, in this stage of edema, we see mucosal edema happening due to increased vascular permeability of tissues. And the submucosal glands proliferate, and goblet cell hyperplasia also may occur. And there's an extravasation of plasma protein into the interstitium. This creates a gelatinous waterlogged stroma. This leads to that edematous soft gelatinous feel of the polyp. Next is the third stage, which is the stage of polyp formation. Now, the edematous mucosa that is formed now becomes pendulous due to the effect of gravity and pressure, and this polyp now starts projecting into the nasal cavity or outside of the sinus ostium. This leads to the last stage, which is the stage of maturation, where the polyps enlarge and persist due to ongoing inflammation. And as a result, due to the ongoing inflammation, it also might lead to secondary infection on it, and the surrounding mucosa may become chronically inflamed. So, these are the four stages of polyp formation. First, there is a long standing allergy, infection, or malignancy. This can lead to vasodilatation and perilymphangitis and periphlebitis, all of it leading to an increase in the permeability of the tissue, leading to edema, leading to increase in mucosal edema, and then prolapse of that edematous mucosa, leading to pedunculation and ultimately polypus formation. Why are polyps from ethmoids multiple and not just one like antrochoanal polyp? Antrochoanal polyp is the polyp that is arising from your maxillary antrum. There is only one maxillary antrum on each side, which is why you only see a single mass. Whereas ethmoids, there is actually multiple ethmoidal cells. They're more in number. That is why you can actually see multiple polyps in case of ethmoid involvement. Now let's talk about if this was not ethmoidal polyp, what other possibilities could be there? And why are we not considering these possibilities? Because there are certain features which are not matching up with this patient. So there are seven different differential diagnoses over here. Deviated nasal septum, chronic sinusitis, allergic fungal rhinosinusitis, inverted papilloma, sinonasal malignancy, rhinosporidiosis, and other granulomatous diseases. So, the deviated nasal septum, if there is a S-shaped deviated nasal septum, that can actually cause bilateral nasal obstruction. Even in case of a single-sided C-shaped uh, deviated nasal septum, on the side which has the wider cavity, there can be actually a hypertrophied inferior turbinate, which can lead to bilateral nasal obstruction. However, this will usually get better if there is a hypertrophy turbinate, it will actually get better on using vasoconstrictor drops. Second, it could be due to chronic sinusitis, but in chronic sinusitis, you will definitely see headache as a feature depending on which sinus is involved. Thirdly, it can be allergic fungal rhinosinusitis, but a very important feature over here is the presence of peanut allergic mucin, which is also known as peanut butter like mucus, which is a thick viscid secretion seen in the nasal cavity. Also, on CT scan, you will see that there is a heterogeneous opacity and not a homogeneous one. This is seen more commonly in immunocompetent young adults and associated with allergy. Next, inverted papilloma. Now, inverted papilloma usually is unilateral, it's very rarely bilateral. And if a mass is present, which is inverted papilloma, it will be firm, lobulated, bleeding on touch, and it definitely has the chance to turn malignant. Next is sinonasal malignancy. Again, sinonasal malignancy is also something that usually starts out as unilateral, but it has a possibility of becoming bilateral. There will be associated bleeding, pain, facial swelling, loosening of tooth, ulceration, even bony erosion on CT scan, and weight loss of the patient. And usually, this is also seen in the elderlies and more in males than females. And there can be certain risk factors like working in the nickel or the wood industry. Next is rhinosporidiosis. So, rhinosporidiosis is a disease where the mass that we see is a reddish, friable vascular mass with white dots on its undersurface representing the sporangia. This mass will bleed very easily and it will be associated with water exposure. And this disease is more commonly seen in farmers. So, none of these features have been seen in this case, which is why it is not a case of rhinosporidiosis. And then there are other granulomatous disease like TB, vaginous, etc., which can be bilateral involvement. But here we'll see ulcer, crusting, granulomatous appearance, systemic symptoms, and here we should definitely perform a biopsy to confirm the disease. So these are all the different differential diagnoses that you could possibly have for such a case with which has presented with a bilateral nasal obstruction and bilateral nasal mass. Now, coming to the last portion of the discussion, how will you manage this case? Now, whenever we talk about management, it is very important to remember management comprises of two parts, investigations and treatment. It is not just treatment. So, first, we'll talk about investigations. Amongst investigations, first, we'll be performing the routine blood investigations. This is more directed towards preoperative evaluation of the patient. Next, we'll perform a diagnostic nasal endoscopy. This is done to see the origin and the extent of the polyp, to see if there is any additional pathology. If you do find any discharge, you can send for culture sensitivity. And if you find any fungal hyphae, you can send it for a KOH mount. Thirdly, the most important test over here is the CT scan of the nose and paranasal sinuses. This is done to see again the origin and extent of the polyp, to assess any invasion of surrounding structures, any anatomical deformities like the concha bullosa or the Haller cell. These are the three important investigations that you definitely have to perform. Now, let's talk a little bit more about diagnostic nasal endoscopy. A very important viva question that will be asked is, how do you perform diagnostic nasal endoscopy, or what are the three passes in diagnostic nasal endoscopy? So, first pass is when you pass the endoscope along the floor of the nose towards the nasopharynx. And what are the structures that you see at this time? First, you look at the nasal septum. You look for any kind of deviation or spurs, the floor of the nasal cavity, inferior turbinate, inferior meatus. So within the inferior meatus is the nasolacrimal duct orifice. Then you look at the choana, you look at the opening of the eustachian tube, which is guarded by the torus tubarius, and behind the torus tubarius is the fossa of Rosen-Miller. And you also look at the opposite side eustachian tube by slightly tilting your endoscope. Other than this, you also look at the adenoids if it is present at the junction of the posterior wall and the roof of the nasopharynx. So these are all the structures that you see when you are doing the first pass. That takes us to the second pass. Now in second pass, the endoscope is passed medial to the middle turbinate. And as the scope is slowly withdrawn, the following structures will be noted. So you see the posterior part of the middle turbinate, the superior turbinate, sphenoid ostium, sphenoethmoidal recess, roof of the nasal cavity, and openings of the posterior ethmoidal cells. So these are the second pass structures that you should be looking at. And last of all is the third pass, where you see the structures within the middle mucus, or the osteomeatal unit. Now, the very important structures that you see over here are uncinate process, bulla ethmoidalis, hiatus semilunaris, the maxillary sinus ostia, ethmoidal infundibula. So these are the three passes of DNE, and what are the structures you see in each one of them. Next, let's talk about what is the anesthesia that you use for diagnostic nasal endoscopy. We use local anesthesia over here, and we usually use 4% xylocaine with 1 in 1 lakh adrenaline. Adrenaline is given here as a vasoconstrictor so that to reduce any bleeding of the nose. Next question is, what is the diameter of endoscope which is used in cases of DNE? So the diameter usually used in case of adults is 3 mm, and in case of children it is 1.7 mm. Last question regarding to D&E is, what angled endoscopes do you use when you're doing the endoscopy? So the most common one that you use is a 0-degree endoscope, and sometimes you may also use the 30-degree endoscope to see places like, for instance, the maxillary ostia, because the angled endoscope will actually 30-degree angled endoscope will actually give you better access to certain places. So this is all about your diagnostic nasal endoscope. Next question is, what are some scoring systems that you need to know for grading polyps? There are 3 scoring systems that you should know. First one is an endoscopic polyp score, which is the Melizier grading system. This is based on nasal endoscopy, and this is mostly used for clinical grading. Second is Lund-Kennedy endoscopic score, which is again based on nasal endoscopy, and this is used for measuring the treatment response. Last of all is the Lund-Mackay CT scoring system. This is more of a radiological testing where it is based on CT scan. And here we are determining the radiologic severity. So these are 3 scoring systems you should know when it comes to grading of nasal polyps. So if you could only Usually, when we order a CT scan of the nose and paranasal sinus, we should get all the cuts, which is coronal, sagittal, and axial. But however, if say you had access to only one of the cuts, which one would you prefer? You would prefer the coronal cuts. And why? This is because coronal cuts are basically taken from the tip of the nose going backwards. So it kind of helps, it acts as a guide for the surgeon to understand the anatomy, the nasal anatomy of the patient. So if you had to choose one view, you would choose the coronal view. This here is an example of the coronal cut of the CT. This is the maxillary sinus. You can see there is some opacity, homogeneous opacity that is seen to be coming out of the maxillary antrum. Another viva question could be, in which view do you of the CT scan do you see the optic nerve in? You see that in an axial cut. If you see in the image over here, this is the axial cut of the sphenoid. You can see that this is the sphenoid sinus. This is the optic canal. This is the superior orbital fissure. So the axial view helps you in noting the relation of the optic nerve with the sphenoid sinus. Next, let's talk about a few common easy viva questions or MCQs that can be asked to you in terms of sinuses. What is Haller cell? Haller cell is basically an anterior ethmoidal cell which is seen to be situated in the floor of the orbit. You can see in the image over here. Second, concha bullosa is actually pneumatized middle turbinate. You can see in the image over here, this is the middle turbinate. Usually the middle turbinate is not pneumatized. It does not contain air. But in this case, we can see that it contains air. So this is known as concha bullosa. This can actually be a cause of nasal obstruction as well. It can be one of the differential diagnosis. Next, let's look at some CT features. In this image over here, you can see in the left nasal cavity, there is a heterogeneous opacity. See, you can see some of them are hypodense and some of them are some of them are hypointense and some of them are hyperdense. So you can see over here, this typical heterogeneous opacity that you're seeing is actually known as the double density sign on CT scan. And this is very diagnostic of allergic fungal sinusitis. Next is Onodi cell. Onodi cell is actually a posterior ethmoidal cell which is seen in a relation to the optic nerve and the internal carotid artery in relation to the sphenoid sinus. So Onodi cell is also a very important cell that you should find out in when you take the CT scan of the patient so as to prevent any kind of injury to these important structures. Last part of discussion is the treatment. So in this case, how would you treat the patient? First of all, it is slightly different from antrochoanal polyp because antrochoanal polyp treatment mainly includes surgery only. Whereas in ethmoidal polyp, actually, you can try medical treatment first. What do you give to the patient? First of all, you give antihistaminics. You give a combination of nasal steroid spray and oral steroids for a week. This will actually lead to reduction of the size of the polyp. Hence, it is also known as medical polypectomy. And you also have to reduce the exposure to the allergen to the patient. So these are all the things you can try in medical treatment. But if you see that despite medical treatment, the polyps are not reducing, not disappearing, in that case, surgical treatment is definitely required. And in that case, you will be performing a functional endoscopic sinus surgery. So, what is functional endoscopic sinus surgery? Again, this is very important for you to know because it's a common viva question. It is a minimally invasive surgical technique used to restore normal drainage and ventilation of the paranasal sinuses by removing any obstructive pathology under endoscopic guidance while retaining as much healthy mucosa as possible. So, when you perform FESS, you need to know what are the steps you would be following in case of ethmoidal polyps. First of all, you do a polyp removal, which is basically meaning that you remove the nasal part of the polyp. You remove it using either a debrider or Blakeslee forceps. This is done so as to improve access and visualization of the rest of the nasal cavity. Next, you perform uncinectomy, where you remove the uncinate process and expose the natural maxillary ostium. After the ostium is exposed, we perform a wide middle meatal androstomy, which allows complete visualization and access to the maxillary sinus. After performing an MMA, we perform an anterior ethmoidectomy, where we remove the bulla ethmoidalis and other anterior ethmoidal air cells. After that, we perform a posterior ethmoidectomy, where we further proceed in dissection and remove the posterior ethmoidal cell. However, at this point, you should be careful that you do not injure the lamina papyracea and the skull base. Next, we perform a sphenoidotomy and a frontal recess clearance if and only it is involved and it is required in that case. Otherwise, you just leave it alone. And then you just inspect for any residual polyp tissue anywhere because ethmoidal polyp are very known for its recurrence. So if any tissue is left behind, it will actually lead to recurrence of the condition again. So you should be very careful about that part. And after which you attain hemostasis and do nasal packing and finish off the case. And last question over here would be, if you are performing a FESS, you should also know what are the complications which are related to FESS. So, when you are asked what are the complications of FESS, you first say that it can be divided into minor and major complications. Now, minor complications are usually the intranasal complications, whereas major complications can be divided into two, orbital and intracranial complications. Now, intranasal complications include bleeding, synecdoche formation, crusting, osteitis. Orbital complications include periorbital ecchymosis, orbital emphysema, nasolacrimal duct injury, intraorbital hematoma, extraocular muscle injury. The most common extraocular muscle which is involved is medial rectus. Then there can also be a direct optic nerve damage. And intracranial complications include CSF rhinorrhea, pneumocephalus, injury to the great vessels or hemorrhage. This is actually a very dreaded injury to the internal carotid artery. Meningitis, brain abscess, encephalocele, frontal lobe damage, and anosmia. So this completes our case discussion today about a case of bilateral ethmoidal polyps. If you have any more questions or any doubts regarding it, please comment below and I'll get back to you about it. Thank you.